Bismillahirrahmanirrahim. Welcome to the channel. This is part 2 for a disease which we discussed in part 1 as juvenile nasopharyngeal angiofibroma, which is a benign disease arising from the posterior part of the lateral wall of the nose, but it is included into the nasopharynx. Though it is a benign tumor, but still clinically, behavior wise, it is aggressive. So that's why it is called as intermediate type of tumor. It exclusively involves the teenager males. Today we will talk about its clinical presentation and investigations. As we know that this tumor, it is arising from the sphenopalatine foramen, which is present in the posterior part of the lateral nasal wall. So after arising from the sphenopalatine foramen, medially it can go into the nasal cavity and nasopharynx, and laterally it can go behind the maxillary sinus into the pterygopalatine fossa and from there to the infratemporal fossa, so that it has got a central stalk which is lying in the sphenopalatine foramen, and medially and laterally the larger sized part of the tumor is present. So that's why we call it as dumbbell shaped mass. So the signs and symptoms will depend upon the extension of the tumor. Tumor may extend into the nasopharynx and it may depress the soft palate when it is large enough, and at that time it will definitely affect the speech of the patient, which will be having no nasal twang then. So that's why the speech will be what we call as rhinolalia classa. It may grow into the nasal passages anteriorly, and then it can cause pressure on the lateral nasal wall and as well as on the medial nasal wall, which is actually the nasal septum, which may be bending towards the opposite side. Due to the pressure on the corresponding turbinates and ethmoidal air cells and the related antral wall, they may go under pressure atrophy. Lateral spread into the maxillary sinus may be responsible for the cheek swelling. It can encroach the orbit through the infraorbital fissures, and it can go intracranially by eroding the skull base and may cause intracranial problems. So keeping in mind all these anatomical features, we can expect a diversity of clinical presentation of these patients, because when the patient will come to you with the tumor confined to the nose and nasopharynx, the two main cardinal symptoms will be profuse recurrent epistaxis, and of course the mass will be there, so there will be nasal obstruction. So when these patients, they are having profuse repeated nasal bleed, chronic anemia is quite expected. Then there will be nasal obstruction due to the mass, which may lead to the stasis of nasal and sinus secretions, and wherever there is stasis, there is infection leading to rhinosinusitis, and its own signs and symptoms may be there. Due to the mechanical blockage of the olfactory area, patient may be having hyposmia or anosmia. Voice may be having hyponasal speech or rhinolalia classa if the size of the mass is too much, and even if it can lead to the blockage of the eustachian tube in the lateral wall of the nasopharynx, there it may lead to the hearing loss and otalgia. Headache may be present either due to chronic sinusitis or the tumor already has invaded the skull base and there is extension intracranially. Pressure on the optic chiasma due to the erosion of the mass into the cranial cavity may cause diplopia, or there can be tenting of the optic nerve by the tumor mass, which will lead to the failing vision, of course. So, depending upon the anatomical extension of the tumor, the signs and symptoms of the patients, you can see too much variety will be there. But again, I am reiterating that two cardinal symptoms will be there in a teenage male with repeated profuse epistaxis and nasal obstruction should arise the suspicion of this benign but still very aggressive tumor, which we call as nasopharyngeal angiofibroma. So nasal bleeding, nasal obstruction, and then depending upon the extension of the tumor, there may be proptosis, there may be, if ear is involved, there may be hearing loss, or if it has gone intracranially, there will be signs and symptoms accordingly. On anterior ionoscopy or flexible nasopharyngoscopy in the clinic, we can check there will be stasis of nasal secretions on anterior ionoscopy, or even a mass may be visible on anterior ionoscopy. On posterior ionoscopy, definitely there will be pink or red colored mass, soft, lobulated, which will be filling the nasopharynx. When disease becomes extensive, the nasal bones may be splayed out. Then intraoral palpation between the ramus of the mandible and the side of the maxilla. One may feel the thickening of the disease with crepes all around. If the tumor has gone into infratemporal fossa, there muscles of mastication may be involved, leading to the trismus. Proptosis, if orbital fissures are involved, and if ethmoid region is involved, then the patient may be what we call as a frog face, in which there will be telecanthus. So, as far as the assessment is concerned, radiology is the main stay of investigations. But of course, we have to start the investigations with CBC, that is the complete blood count, because main symptom of the patient will be repeated profuse epistaxis. So we should look for the baseline hemoglobin of the patient, which in such patients quite expected that it will be low already. And then if the patient has to be subjected for surgery later on, then we should go for blood grouping and cross matching as well. As far as radiology is concerned, plain lateral view of X-ray paranasal sinuses, it will show us the anterior bowing, what we call as this is the maxillary sinus, this is its posterior wall, this arrowed area, soft tissue density mass, which is pushing this posterior wall anteriorly forward. So this forward displacement of the posterior wall of the maxillary sinus, or what we call as anterior bowing of the posterior wall of the maxillary sinus by a soft tissue density mass, this is called as HOLMAN-MILLAR sign, and this is a typical plain radiographic appearance of an angiofibroma. But of course, CT scan is the investigation of choice, which will give us better bony details and extension of the tumor. And with MRI, it is very helpful to stage the disease. And even we can go for angiography to find out the feeding blood vessel, because it is a vascular, highly vascular tumor. And even we can go for embolization later on. But what is important, that even in a suspected case of angiofibroma, never go for biopsy. Biopsy is clearly contraindicated because of brisk risk of very profuse hemorrhage. A vascular mass on CT scan of nose and nasopharynx located posterior to the maxillary antrum, which is pushing the posterior wall of the maxillary antrum forward. That's what we call as Brown's sign. On plain X-ray and on CT scan, this HOLMAN-MILLAR sign, or it is also called antral sign, or collectively they call it as HOLMAN-MILLAR antral sign, which is actually the anterior bowing of the posterior wall of the maxillary sinus. So as I told you, in more than 80% of the cases, anterior bowing of posterior wall of maxillary sinus, as you can see in this CT scan, this is on the normal side. See, the posterior wall of the maxillary sinus, its extent, but here this posterior wall is pushed forward by the tumor, which is coming from the nasal cavity and the nasopharynx. And here you can see there is supplying of the pterygoid plates as well on this side as compared to the pterygoid plates on this side. Excuse me. Then is Hondusa sign. This is widening of the gap between ramus of the mandible and the maxillary body on the affected side as compared to this ramus and this maxillary body on the normal side. This is gap is increased on the diseased side. This is called Hondusa sign. This is the differential diagnosis of HOLMAN-MILLAR sign. This is not the differential diagnosis of angiofibroma, but if on radiology there is anterior bowing of the posterior wall of the maxillary sinus, it can be due to, of course, top of the list is juvenile nasopharyngeal angiofibroma. Then if schwannoma at that particular site, fibrous dysplasia, even nasopharyngeal carcinoma can cause this, and tumors of the infratemporal fossa. So this is the differential diagnosis of HOLMAN-MILLAR sign, you can say, on radiology. On radiology, there can be HARAN sign, which is quadrilateral appearance of this pterygoid plates. This quadrilateral appearance of this pterygoid wedge as compared to a bit triangular pterygoid wedge on the normal side. Chopstick sign is a post-operative appearance of the medial and lateral pterygoid plates as two separate sticks due to the drilling and removing of the pterygoid wedge as compared to on the normal side. So this is chopstick sign. So as I told you, CT scan is the mainstay and investigation of choice, and both plain and contrast CT scan should be requested for because this is a vascular tumor. And on this axial cuts and on the coronal cuts, you can see on axial cuts, this is the soft tissue density mass, you can see extending up to the nasopharynx involving the pterygoid plates, and in coronal cuts you can see the same mass. It is skull base has been eroded and it is going intracranially. So there is intracranial extension here at this particular site. This is the soft tissue density mass, or this is angiofibroma, which is confined to the nose and nasopharynx. So this is what at stage 1 still, very initial stages. Again, you can see that some mass is there in the nose and nasopharynx, and it is involving the sphenoid sinus as well. Here you can see there is widening of the left side sphenopalatine foramen, and the lesion, it is filling the left choana, which is so much widened as compared to on the right side, and it has gone into the sphenoid sinus. Again, the mass, homogeneous mass, which is, you know, with widening of the sphenopalatine foramen, involving the pterygoid plates as well, and pushing the posterior wall of the maxillary sinus forward. This is MRI on the left side, and on the right side is the excised nasopharyngeal angiofibroma, and you can see this is a dumbbell shaped, two broad ends which are uniting with one another with a thin stalk. Again, some MRI pictures. Now you can better read these MRI pictures. So angiography, either carotid angiography or even 4-vessel angiography, in which 2 carotids and 2 vertebral arteries are included. They will show us the vascular nature of the disease and the feeding vessels and extension of the tumor. And in addition, during angiography, embolization of the feeding vessel with gel foam can be done preoperatively, which will make the tumor shrink and less blood loss during surgery or during resection of the tumor. Biopsy, as already mentioned, it is contraindicated in suspected cases of angiofibroma because it will cause profuse bleeding as there is no muscular coat of the vessels. So this is the angiography, how the leash of blood vessels and the supplying main feeding vessel will be cleared. Here you can see this is the carotid, and from there this is the internal maxillary artery, and its diameter is too large as compared to the normal one. Again, this is the angiography. Now staging is very important, and the purpose of staging, it is basically for prognosis and therapeutic purposes. There are different staging systems with different names. FISCH classification is there, MILLAR's classification, Anterior's, RADKOWSKI classification is there, but this FISCH staging system is usually followed. There is some modification of this system which is now included into Anterior's classification, or some people call it as a combination of two, that is Anterior-FISCH classification. This is most robust and practical, and it defines clearly the extension of the tumor, and by that we can plan that which surgical approach will be applicable for that particular patient. So FISCH classification says that type 1 is when the tumor is confined to the nasopharynx and nasal cavity without any bone destruction. Type 2 is when the tumor has gone laterally into the pterygopalatine fossa and involving other sinuses, and of course it can happen only when there is bone destruction. Type 3 is tumor has more extensively gone laterally into the infratemporal fossa, and even above it can go into the orbit. And type 4 is of course when the tumor is having intracranial extension after eroding the skull base. Then there is Radkowski's classification. It gives us a bit minor details as well. That type 1A is when the tumor is limited to nose and nasopharyngeal area. 1B is when there is extension into one or more sinuses. Type 2A is minimal extension into pterygopalatine fossa. Now the tumor has started going laterally. Stage 2B is when there is occupation of pterygopalatine fossa without extension to the orbit. 2C is when infratemporal fossa extension without cheek or pterygoid plates involvement. 3A is erosion of skull base, and 3B is erosion of skull base with intracranial extension with or without cavernous sinus involvement. Then MILLAR staging system is very straightforward. The tumor is in the nose and paranasal sinuses, but except the sphenoid with or without erosion of the bone. Then tumor has extended into the orbit, or it is protruding into the anterior cranial fossa. And type 3 is when it has involved the brain, and but still it is resectable with its margins. And type 4 tumor is when it is unresectable intracranially. Now this is the most currently accepted staging system, that is the Anterior's staging system. As I told you, it is just like modification of FISCH classification, you can say. So type 1 is the same. The tumor is limited to the nasopharyngeal cavity. Bone destruction is negligible, and if any it is there, it is limited to the sphenopalatine foramen only, from where the tumor is originating actually. Type 2 is when tumor is invading the pterygopalatine or maxillary ethmoid or sphenoid sinus with bone destruction. Type 3 is tumor is invading the infratemporal fossa or orbital margin. Type 3A is without intracranial involvement, and type B is with intracranial but still extradural involvement. And type 4 is intracranial intradural tumor without the infiltration of cavernous sinus, pituitary fossa and optic chiasma. And type 4B is when there is intracranial intradural with infiltration of cavernous sinus, pituitary fossa and optic chiasma. But this is the signature statement that from stage 1 to stage 4A, up to 4A, surgery is the treatment for angiofibroma. only very few cases with the type 4B that may require radiotherapy, because there the tumor may be unresectable. So the treatment of choice for angiofibroma is surgery. Differential diagnosis for angiofibroma: any mass there in the nose nasopharynx, like enlarged adenoids, infected anthraconal polyp, hemangiomas, rhinosporiodosis, inverted papilloma. In addition to that, any midface or anterior skull-based tumors like osteomas, craniopharyngioma, olfactory neuroblastoma, chordoma, chondrosarcoma, rhabdomyosarcoma, and nasopharyngeal carcinoma should be included in the differential diagnosis of juvenile nasopharyngeal angiofibroma. So, typical history, physical examination and radiology. As we discussed in history, teenage, exclusively male with recurrent profuse epistaxis and nasal obstruction. Other symptoms, depending upon the extent of the tumor and advanced stage of the tumor, there can be hearing loss, rhinolalia classa, hyposmia or anosmia, even swelling of the cheek, dacryocystitis, deformity of the head and hard and soft palate, orbital proptosis. On a physical examination, there will be smooth lobulated mass in the nasopharynx or lateral nasal wall, which may be pale purplish, reddish gray or beefy red, and it is compressible. It may bleed on touch. So with that, we come to end of this session. If you think it is beneficial for you, please subscribe the channel and share it with your friends. And in next part, we will continue with the treatment of this. Thank you very much for watching.